Assalamu alaikum. I'm Dr. Maham, the co-director of the academic wing of Ventilators for Pakistan, and I welcome you all to the fifth session of our COVEB series, where we will be shedding some light on the public health concerns related to COVID. I would like to reiterate that this session is part of the educational activities taken up by Ventilators for Pakistan. Ventilators for Pakistan has become a name of its own, not just thanks to the amazing vision of its founders, Dr. Sabah A.K. Akhtar and Dr. Abez Tariq, but also due to the unrelenting efforts of all of its members. This week, we would like to talk about the amazing work being done by our awareness team. The director of the awareness team is Mr. Ali Fateh, and the members include Dr. Pinar Farooq, Dr. Nismat Javed, Mr. Rebel Zahid, Dr. Dania Ansari, Dr. Abu Bakr Sheikh, Ms. Gul Said, and Dr. Sana Khan. The awareness efforts have been directed towards making available to the general public an easy to understand language so that it can be implemented in the daily lives. Everything that's put out is meticulously researched and proofread. In the quest to convince the masses to remain vigilant, an outside the box graphical dialogue between animals about taking precautions was created to target Eid. It received a promising response. The next step would be to audio video ads focusing on mass events to establish the importance of social distancing. VFP Awareness Team is a diverse group of individuals from all walks of life, keeping the perspective interesting and relevant. The agenda is to make a difference in the fight against COVID-19. Thank you for your efforts. Over the weeks, we will try to share all the efforts that VFP has been making to combat this deadly disease and its effects. Now, without further ado, I would like to introduce my co-director and my co-host for the evening, Dr. Mavish Arkin. Mavish.
Thank you so much, Dr. Maham. Assalamu alaikum. It is an honor to co-host the COVEB educational series. I'm the co-director of the academic wing for VFP and also the co-founder for Yardım Foundation. My sister Maham and I, we founded this organization about a year ago, and it was done with the sole intention of helping the marginalized sections of our nation in whatever way we can. We currently have 3 running programs. The Yardım Dental program is our pioneer initiative. We organize dental camps to create oral hygiene awareness, free dental screenings, and provide free dental treatments in the underprivileged communities. We also have a mental health awareness campaign running on ground and online, the agenda of which is to spark a conversation which will help tackle the stigma in our society. Our third initiative is the FRP program. We started this during the pandemic, and we have so far helped 800 plus families and continue to provide monthly ration to verified families with no means of support. Now I would like to mention some personalities without whom this web series would not have been possible. The patron-in-chief for this series is Professor Emeritus Lieutenant General Mahmood Ahmed Akhtar, Hilal Imtiaz Military. Our patron is Professor Samia Naimullah, recipient of the President of Pakistan Gold Medal by Pakistan Pediatric Association. Thank you, ma'am and sir, for your support. I would also like to take this opportunity to talk and thank Rawalpindi Medical University, which has accredited these educational series for all of you to enjoy. Thank you to the Vice Chancellor and the entire medical education team of RMU. Over to you, Dr. Maham.
Thank you, Dr. Mavish. Now, with a lot of pleasure, I would like to welcome our first speaker for the night, Dr. Faisal Khan, who is a public health physician and a medical epidemiologist. He completed his medical training in Pakistan, followed by a master's in public health in Australia. He has worked extensively in public health program design, implementation, and evaluation with a particular interest in HIV/AIDS and tuberculosis. Over the last 22 years, he has worked in Pakistan, Australia, Vietnam, South Africa, Botswana, and the United States on a variety of communicable diseases, disease control issues, including TB, HIV, co-infection, MDR-TB, hepatitis B and C, polio, and the WHO expanded program on immunization. An area of particular interest to him is the socioeconomic determinants of disease. Dr. Khan served as director of the HIV/AIDS and STD program in the state of West Virginia from 2000 to 2004, and a similar capacity in Massachusetts from 2004 to 2006. He has also served as Director of Health Services Research and Quality Improvement for a multi-state healthcare quality improvement peer review organization from 2006 to 2010. He holds adjunct faculty appointments at the St. Louis University School of Public Health and the Washington University Institute for Public Health, and is an active member of the National Association of City and County Health Officials. He joined the St. Louis County Department of Health in 2010 and served as Director of Communicable Disease Control. He joined the Samuel U. Rogers Health Center as his CEO in October 2018. Thank you so much for joining us, sir, from all the way from United States, and it's an honor to have you as a speaker over here. Welcome.
Thank you. I appreciate it. And Please pardon me if there are any technical glitches that I inadvertently cause. Um, Dr. Maham, thank you so much. I am in awe of this agency, this organization, and the work that you guys are doing. My classmate, Dr. Sabah put me up to this, and I reluctantly agreed. I have to warn you, I was never the brightest bulb in our class. There are several colleagues of mine who've gone before me who, in fact, were medal contenders, and so they were the academic top guns, as it were. The fact that one of our esteemed teachers, somebody who we hold in very high regard, who was principal of the Army Medical College when we were first year students, both Sabah and I in the same class, General Mahmoud Akhtar Saab is watching this, is very, very intimidating. Um, and so if there's something that I misstate, General Saab, in case you're watching, I truly ask for your forgiveness. It's not because I was slack in my preparation. I assure you, you did your job well. With that being said, a disclaimer. Somebody located in the United States should be the last person talking to colleagues in Pakistan about COVID-19 at the moment. 162,000 Americans are dead of COVID-19 as of today. And so it's a very sobering experience. And in many ways, the United States serves as an example of how not to do COVID-19 control. Unfortunately, in spite of the fact that we had the best agencies, the most resources, the personnel, the infrastructure available to us, the politicization of what is essentially a public health crisis has led to the mess that we're in today. And so I'll talk a little bit about that today as a cautionary tale, but also try to focus on what we can do in Pakistan. And at heart, I will always be a Pakistani. To contend with the resource constrained settings that we have. You go to war with the army that you have, not the one that you wish you had. And unfortunately, that's reality for us. So let's get started. And I'm going to try and share my screen. I trust you'll let me know if it's working. Can everybody see that?
Yes.
Yes, sir.
Let's begin here, and let me go into presentation mode. All right. So, intro is being done, and thank you, Mavish and Maham. That intro was far too flattering. Essentially, this is a case of us getting the public health system that we're willing to pay for. Any system that is funded at a D grade level cannot be expected to mount an A+ response when a pandemic hits. And the middle of a pandemic is not the time to begin to juggle with what to do and what sort of infrastructure or systems to put in place and what sort of plans to develop. Those have to be done years, if not months in advance of when the actual pandemic hits. If you didn't do that, then there's no point arguing about that. It's time to move on. It's time to go into crisis management mode rather than focus on a nationwide or a statewide pandemic response plan. And there is a method to that madness, and I'll touch upon that a little. In terms of the United States, if I could use that once again as a cautionary example, this is an excerpt from an IOM Institute of Medicine report in 2002, which focused on the future of public health in the 21st century. Within the United States, we have several think tanks which work actively to look at various aspects of infrastructure and policy across the country. The Institute of Medicine serves as that for the public health infrastructure as well as the world of medicine. And their assessment in 2002 could not have been more damning. Vulnerable and outdated health information systems and technologies, which means we didn't have the disease surveillance systems in place, an insufficient and inadequately trained public health workforce, not to mention underpaid and underappreciated, an antiquated laboratory capacity, and a lack of real-time surveillance. That is very, very important, a lack of real-time surveillance. And this was back in 2002. Now, for those of us that are old enough to remember 2002, I'm looking at you, Maham and Mavish, and my other young colleagues, that was in the immediate aftermath or just before the intervention in Iraq began. And one of the myths created by the US government at the time was the hype around the possibility of bioterrorism, specifically related to smallpox and anthrax. I remember as an epidemiologist back then being asked to be vaccinated for smallpox in preparation of what the government had assured everyone was a real threat. The fact is that hundreds of millions of dollars, if not more, were spent on preparing the public health system to respond to what was anticipated as an imminent public health threat. That never came about. It was based on a pack of lies. We all know the aftermath. 6 months later, the United States invaded Iraq, and the rest, they say, is history. Regrettably, between 2003 and 2020, 17 years have gone by. None of these things have improved. If they have, it's been in increments, and the weaknesses still remain. So keep this in mind, and by all means, view anything that the United States tries to preach to the world in terms of public health with a grain of salt. Some recommended reading. If you have not already, anyone who's listening or watching, these are two books that shaped my worldview and really encouraged me to take up public health as a career. The first one is on the right, The Coming Plague, Newly Emerging Diseases in a World Out of Balance. They're both by the same writer, by the way, a very dear friend of mine, Laurie Garrett. She is a scientific journalist. We call her an honorary epidemiologist. She's spent a lifetime working on everything from HIV/AIDS to Ebola to smallpox, anthrax, H1N1, SARS, MERS, and now, of course, COVID. And the second one, which is even more important in terms of trying to understand what happened across the world. Why is it that a pandemic arrived in the year of our Lord 2020? We've been preaching and preparing for it, seemingly, for the last 30 years, and suddenly we find ourselves in a crisis as opposed to responding effectively to it. All those arguments are captured brilliantly in this book, Betrayal of Trust, The Collapse of Global Public Health. It reads really, the caption is very apt. It reads like a Robert Ludlum thriller. You will not be able to put it down once you start. Now, in terms of what goes into preparing for a pandemic, once again, a disclaimer, all of this has to be done well before a pandemic actually hits. Of course, you prepare for an emergency. You develop a pandemic preparedness plan. I know that's a mouthful, but it really is a comprehensive plan with algorithms, defined roles and responsibilities, how different scenarios are going to play out. And it's only as effective as how many times and how effectively you rehearse it, you critique it, and prepare after-action reports for review and improvement. I know that sounds awfully militaristic, but that is what it is. And that's exactly the way we do it in the US. Now, don't hold my feet to the fire in terms of, well, if you're so smart, how come 162,000 Americans are dead? There's a whole lot of reasons for that. If they had listened to Dr. Fauci, that would not have happened, or the death toll would have been far lower. Surveillance systems. You're only as good as a response team if the real-time data filtering into your computer screens is accurate, timely, and can be validated. Any fragmented system, such as, let's say, Pakistan, where the federal health responsibility was devolved some years ago back to the provinces, well, that leaves you with a void at the national level where coordination and resource direction becomes an impediment. You cannot leave it to provinces alone to come up with surveillance systems. That has to be driven at the federal level. This is something that I know that Dr. Amir Ikram, Major General Amir Ikram, who was director of the NIH until recently, one of our esteemed seniors, somebody I respect immensely, and his team did their very best to teach provincial colleagues, to prepare them to collect data and report it through active case finding, etc. How well it worked, only time will tell, of course. Case investigation and treatment remains the bread and butter of any disease investigation. In this instance, case investigation is assigned essentially to a nurse or an epidemiologist or a community health worker. The treatment component, unfortunately, remains up in the air. We simply don't know enough. Yes, clinical knowledge has improved. Yes, there are a lot of studies going on, but that is one persistent question that people will ask of public health officials, much to their chagrin. If you're so worried about this, what are you going to do if we come down with it, if there is no treatment? Preventing the spread of disease in the community, easier said than done. In the United States, getting people to wear masks and wash their hands is an affront against God, it would seem. There are parts of the United States where people have actively rebelled based on political ideology, encouraged by national leadership against public health imperatives. And so the very act of wearing a mask becomes an act of rebellion. That is highly regrettable. The basics remain the same as our colleagues have covered. Wash your hands, wear a mask, keep your distance, and for the love of God, stay home and stay away from crowded places unless it is a dire emergency. You need to put your life on pause for the time being. Most critically, any plan that does not address the maintenance of essential services, and by that I mean food, water, electricity, the supply of medications, transportation to and from critical areas of work. It is very easy for public health officials to preach this until they go blue in the face. People do not respond unless they know that their needs are going to be taken care of. And this is where the federal government needs to step up its game. People need food if they're not able to work. Day laborers need to be able to be guaranteed an income if they cannot go to work. So those things are not easily dealt with. And the scope of a pandemic response plan cannot cover every scenario. You require the cooperation and the active participation of everyone from the Ministry of Finance to the Ministry of Economic Affairs to Social Services, etc. Research and evaluation is always an adjunct to any pandemic response. You're only as good in terms of improving in increments as good as your systems for collecting data and conducting research is. The evaluation component cannot be underlined enough. And by evaluation, I don't mean critique. You did this wrong. You could have done that better. There is a method to the madness. You have to be able to quantify for an objective review exactly what did not work to the extent that you thought it would. What would you have done differently? And it is a team effort. Testing and revisions to the state national plan, the rollout where the rubber meets the road, so to speak, is critical. There have been several missteps in the United States, as all of you have seen. It is covered in gory detail every day on CNN and at the comedic routine that is the White House pandemic briefings led by our fearless leader. I will say no more. Pakistan has done rather well in terms of implementation and testing and has drawn praise from the World Health Organization and other countries. I know that sounds strange, but that is an actual fact that gives me some hope. We must not compare ourselves to countries like New Zealand or Britain or anywhere else, or even South Korea, for example, or Singapore. They are very different countries, smaller countries, different sorts of populations, easier to control ports of entry and exit, easier to roll out plans, a population that really does not rely on daily earnings as much as they do on regular jobs with social structures and social security systems in place to ensure that people remain in their home and receive the money that they need to survive. I think we really need to focus on what we can do in our circumstances. Any plan being rolled out depends on a partnership between public and private entities. Public health officials really sitting down with business leaders and helping them work through every single facet of their business to determine how they will ensure continuity of operations in the middle of a pandemic. This does not end with disease control alone. This continues well after a vaccine is available, because remember, let's assume, the population of the United States, 330 million. If we had 500 million doses of the vaccine dropped on us, off a safe and effective vaccine dropped on us today, miraculously, we would still have to have a system in place to distribute them, to administer them, and to follow up with people who may, God forbid, suffer side effects, because let's face it, there is that tiny aspect of that happening. And all the while, we would have to deal with the say no to vaccines community that seems to have gained strength in the middle of the pandemic. Part of that effort begins with sitting down with businesses and helping them develop their own individual plans as to how they will help deliver the vaccine to their staff and families. Everyone cannot simply head to the National Institutes of Health or to their local public health department to get a vaccine. Will be overwhelmed. Most public health departments in the United States have no more than 10 staff. You have 2 nurses that essentially perform 80% of the functions assigned to public health in rural communities. It's only in the bigger cities, New York City, Miami, San Francisco, LA, etc., St. Louis, that you would have a decent sized staff. So if you look at, and by the way, I didn't really do any creation on this. This is from the Harvard Business Review. And the fact that the Harvard Business Review would try to come up with a template to teach its business membership about creating a pandemic preparedness checklist tells you how seriously businesses are taking this pandemic, because the bottom line for them is the money component, and they've been hit about as hard as they possibly could. We're looking at a long-term economic recession thanks to the pandemic. This is now lifeblood for them. This is an existential issue. Let's not ignore the fact that there are special populations that public health will have to focus on and is focusing on in working actively with all these agencies. Correctional facilities. We know this pandemic has spread like wildfire in correctional facilities. Up to 80% of jail populations and juvenile justice facility populations have come down with COVID. Now, most of them are fit, relatively fit young individuals on the juvenile side, so they will hopefully, knock on wood, recover. But as far as the staff are concerned, the administrative staff, the corrections officers, as well as inmates, adult inmates with chronic conditions, that is a recipe for disaster. And that is now unfolding in places like California and Cook County, Chicago, which has one of the largest correctional facilities in the United States. Schools are another potential disaster area. I'm sure you've seen the media coverage related to the political controversy that's been created around the forced reopening of schools, as well as the threats from the federal government in terms of funding. The fact is that schools are really dependent on federal funding for operations. So in many instances, school districts have been forced to make the decision of having in-person classes only because they were at risk of losing their federal funds. How has this panned out? I'll give you one glorious example. In the state of Georgia, which is led by a Republican governor, a loyalist to our president, he basically forced all school districts to open. 5 days after one school district opened in Georgia, 110 students and 36 staff tested positive for COVID and had to be quarantined and isolated. The school system was shut down until they could figure out what was going on. If you do stupid things repeatedly expecting different results, that's what happens. So that's a cautionary tale. Pakistan has taken the right approach, the proactive approach in trying to be very mindful about how they go about doing it. And we're still not out of danger yet. Dormitories are another issue. University and college settings, think about how rapidly something like meningitis, which we worry about all the time in public health, spreads. COVID is going to decimate that population, possibly not to the extent of causing a high degree of mortality. They're relatively younger, they're relatively fit, but one death is one death too many. And if it can be avoided, it should be avoided. Working with administrations at universities and colleges is another issue that we're engaged with every single day. Entertainment venues, yes, you cannot go to the cinema. No, you cannot go to a concert. If somebody's holding a concert, stay the heck away from it. Please don't look at the United States as an example. Once again, people and agencies and organizations thrive on this so-called idea of freedom, although I spell it FREEDUMB, because they do things that place the health and well-being of others at risk. There is a 250,000 biker rally going on in Sturgis, North Dakota, as I speak. Nobody is wearing a mask. Guess where the next epicenter of a community-wide COVID-19 outbreak will be? Sports venues fall into the same category. All sports have been canceled. The United States practically runs on seasonal sports. If you took that out of the equation, people wouldn't know whether to scratch their head or slap themselves. That's their addiction to it. And it's been nerve-wracking for a lot of people. I'm not a sports fanatic, but to watch football leagues, baseball leagues, basketball leagues, and even soccer leagues suspended. State and national parks, wherever applicable, were forced to open because people were going stir crazy. Public health officials have been vilified for saying, for the love of God, control the number of people you allow into any state or national park. Just because they're outdoors doesn't mean they are staying far away enough from each other or wearing masks all the time. It is impossible to expect people to wear masks when they're hiking or they're indulging in outdoor recreational activities. Regrettably, that has fallen on deaf ears, and that continues to be a challenge. Law enforcement and military. If you look at Pakistan, just imagine for a moment if 50% of law enforcement and up to 30 or 40% of military forces came down with COVID. It would create a very, very serious existential national security crisis. The armed forces have taken extraordinary steps to ensure that does not happen. And I watch that with great pride, of course, from this distance. The United States is no different. The armed forces have their own infrastructure, their own public health command, their own uniformed public health service. They really went into action very quickly. The case rate in military facilities in different Army or Marine Corps or Navy facilities is very low compared to the general population. Airports and ports, oh dear God, that is a very different headache altogether. I cannot tell you the number of hours we've had to spend with airport officials and port officials, both at ports of entry into the United States, as well as the riverine ports that run all across the United States, catering to recreational enthusiasts, as well as the barge traffic that a lot of the United States relies on for coal supply and wood supply. The fact is that one infected individual can turn into a super spreader and create chaos up and down the channel is a fact that we had to draw on a whiteboard for people to understand. We even cited them the example of the super spreader that was studied in South Korea. And I'm sure you've seen the study, which talked about 80% of the cases in one major outbreak attributable to one super spreader who took the train from a northern city to a southern port in South Korea. infecting everyone along the way. He was a salesman, so he had to go meet people, knock on doors, and so on and so forth. It is a fascinating study in how quickly this can spiral out of control. Now then, now that we've talked about South Korea, the wise thing to do is learn from the mistakes of others, as opposed to insisting on making your own and then arriving at the same conclusion. The United States is in the middle of doing the latter. South Korea instituted a test, trace, and contain policy, which has now been adopted by the United States. 162,000 deaths, and God knows how much angst and economic recession too late, but it is on the right track, I suppose. Back in January, South Korea's first case was reported on the 20th. By the middle of February, leading on to the beginning of March, the reported cases were in the thousands, in fact, reaching a peak of almost 1,000 infections daily on the 29th of February. As of the end of April, cases were back in the single digits. How did this miraculous dip occur? It occurred because South Korea stood up a prepared, trained, and heavily equipped and tech-savvy public health workforce to test, trace, and contain cases. As soon as reports came in, people were hyper-vigilant. Public transportation had to be shut down in areas where transmission was high. They instituted a series of so-called smart lockdowns, which Pakistan has also experimented with. And that combo, in fact, resulted in what we see today. Now, it stands to reason that COVID being what it is, there would be second or third waves. There would be ongoing community outbreaks related to one event or one individual or a couple of individuals who broke protocol, etc. And those continue to be a challenge for South Korea. But they have very much, in terms of what we can say today, contained the outbreak. New Zealand is another glorious example. Although New Zealand is an island with a very small population, it's easy enough for them to shut down their ports and airports, exactly what they've done. But more importantly, it's been a study in how effective political leadership can be if they listen to public health as opposed to political dogma. And that is the difference between New Zealand, South Korea, and the United States. Pakistan has been a mixed bag. I wish there would have been more proactive and assertive pronunciations, let me put it politely, coming down from the leadership, but it is what it is, essentially. You have to deal with the deck of cards you're dealt with. And in those terms, Pakistan's leadership has not done a bad job at all. In fact, it has probably done one of the better jobs in comparison to its peers. Now then, one of the major crises that occurred within this pandemic between really essentially the beginning of the pandemic, end of February through the end of April, was COVID anxiety. Everyone was worried sick about it. There was panic on the streets. There was a rush to buy every single roll of toilet paper. I'm sure you've seen the comedic scenes in supermarkets in the United States, as if toilet paper was going out of fashion. All the Muslims in the United States joke about the fact that that really wasn't a concern of ours. But that will be my 2 bits of toilet humor today. Managing expectations is probably the only way that public health officials can meaningfully contribute towards the discourse. The fact is that one of the gurus of crisis communication, Peter Sandman, wrote an excellent book that laid out in clear terms a very good formula where he said danger is equal to outrage plus facts. And what that means is the variable equation in that formula is outrage. If the outrage is high, the perceived danger goes through the roof. If the outrage is moderate and managed well in terms of public anxiety and response, you can lessen the danger. The facts are what they are. They will not change. They will remain constant. It is an airborne transmission. Yes, you need to be apart from each other. No, you cannot hug each other. No, you can't shake hands. And for the love of God, stay home unless you absolutely have to be somewhere. All those things remain constant. The fact is that the public's outrage is based on the anxiety that they see coming out of the 24/7 news psycho bubble, if you can call it that. And that is very, very difficult to manage. At every single media event or news conference, public health officials have been bombarded with questions about why are you lying to us? Why are you hiding the fact that there are secret experiments taking place in facilities in the United States where people are being forced to take experimental vaccines and so on and so forth. The conspiracy theories and the myths just abound. You will remember, my dear friends, the insane conspiracy theory that seemed to be rife in Pakistan thanks to social media, which centered around this insane idea that COVID-19 patients in hospitals were somehow being abducted and necropsied and their brains shipped to the United States to perform experiments related to COVID-19. I kid you not. I watched that video and I'm sorry, I don't have words to describe it. Those three magic words for all clinical colleagues watching and listening, I don't know, have never been more important than now. When people ask us questions about COVID, it is okay. In fact, it is preferred to use those three words. The fact is that we don't know. The fact is that we really will not know for some time. There is a tremendous rush to publish and to add to the body of knowledge that we have about COVID-19, but it will take time before that wealth of scientific evidence matures to the point that we can consider it gospel truth and take it forward. Yes, clinical care outcomes have improved as a result of those studies, and we are in a much better situation today than we were 4 months ago. But the fact is that false reassurances and bravado does not add anything to the equation. Please use those words judiciously. I don't know, because we don't, and we have to wait and see what happens. In terms of what we're looking at, I will cite you the example. Now, if any of my colleagues, my smarter friends are watching, any of my classmates, you know who you are. You're the ones that used to read the Harrison's textbook of medicine when I was stuck reading Davidson and I couldn't get past that. You know who you are. You know exactly who you are. And I know you're smiling right about now. You will remember that one of the authors was Dr. Fauci. He said something very profound the other day, which I've quoted here. This is a marathon, it's not a sprint. The fact is that even with a vaccine available to us, hopefully within a year, optimistic scenario, COVID will be with us for many more years to come. And I think that reality is now beginning to set in, both for our clinical colleagues and our public health colleagues. And we have to temper expectations on all fronts, starting with our family, our friends, our clinical colleagues, the general public, wherever we might be in social settings, and make sure that people understand that there is no magic silver bullet for this. We simply cannot predict what will happen 2 years from now. We might still be struggling with this. And don't forget, we are on the cusp of the regular flu season. If we have a worse than usual flu season, if, God forbid, the flu vaccine somehow does not cover a strain that ends up being in circulation, the comorbidity and comortality, frankly, that influenza and COVID will cause is simply unfathomable at this point in time. What we can do is practice universal precautions and keep preaching that mantra. We simply cannot take our foot off the gas pedal on this. This, once again, is a marathon. This is not a sprint. Pace yourselves. Turning off the news, limiting social media. I know I'm one to talk. And maintaining a positive attitude are things that we can control. The stress within hospitals, within clinical settings, is simply indescribable. I remember being at these combined military hospital in Lahore 2 years ago to see a friend of mine. And the scenes that I saw in the waiting area of the outpatients department were just unbelievable. It seemed like there were 10,000 people crammed into a room that could barely accommodate 3,000 people. And these were all desperate individuals. They were there for a genuine reason. They'd come to see the doctor. I could not imagine how my friend and his colleagues were dealing with so many patients at the same time. That level of stress will be amplified even further. I know that is difficult to imagine, but yes, it is happening, and it will continue to happen as COVID unfolds, despite our best intentions and efforts. And I wish you all the very best in dealing with it. All right. That concludes the PowerPoint slide portion of my presentation. You'll forgive the early hours today because it is still Sunday morning in St. Louis. I haven't had my morning cup of coffee. I know it's evening in Pakistan. I wish you all the very best. My thoughts and prayers are always with you, and I have watched with growing interest and admiration in the manner in which colleagues like Saba, Mahawesh, and Maham have gone about setting up ventilators for Pakistan and creating foundations to support each other and other colleagues through this. Thank you so much. It has been an honor.
Thank you so much, sir. That was an amazing session. We have a bunch of questions. If you're okay with it, we'll start the question answer session.
Absolutely. If it's a difficult clinical question, I've warned my classmates watching, I'm going to bounce it back to them. But go ahead, please.
They're pretty general for now. Okay, so the first question is that schools are set to open in September in Pakistan. And do you think that's a good idea? Because the number of cases in Pakistan are also steadily increasing these days. So what is your take on it?
I will give you the same advice. So let me just repeat what I told the school district where my children go to school here. It is not a good idea to open schools. Now, that is easier said than done for me because I could tell them switch to an online format. Doing that in Pakistan is very difficult. And by the way, even in the United States, 30% of school children do not have access to regular or reliable internet at home. So here, the school district has had to provide hotspots and laptops, etc., for children to be able to do that. But no, the fact is that it is impossible to control the transmission of disease. No, wearing masks is not enough. And we know from our school settings in Pakistan, I went to school there, social distancing is something that will never happen. Kids are finicky. They won't keep their masks on. Hand washing and hand sanitization is another challenge. Plus, the threat may not be immediately to the kids themselves, but to the teachers and the other staff around them. So it is a very bad idea. And yes, I'm worried about that. I read that as well.
Thank you, sir. Okay, so the next question is, which country can be compared to Pakistan in terms of its ability to combat COVID-19? And how has Pakistan performed in comparison?
I think, comparisons are always difficult to make. I would suggest that if we had to establish a point of comparison, compare ourselves to Bangladesh. And I say that because I've had the honor of being to Bangladesh. I've had the honor of working with Bangladeshi officials. They really invested a lot in their public health infrastructure over the last 30 years. It was an existential necessity for them, and it has paid off dividends. They've done a lot of good work. Bangladesh would be a good example to use. They have gone about doing exactly what needed to be done in their resource constraint settings, and many of those are similar to ours. The other point of comparison I would establish in some parts, but not all, would be with our neighbor, India. Their public health infrastructure is actually pretty sound. Their challenge is 1.1 billion people or more to deal with. It is a staggering number of people to take care of, and that is where they've fallen short. When that mass of people rely on public transportation to get to and from work, they need to be fed, they need to go back home and stay home. We've all seen the stories of the migrant caravans in India. Those are formidable challenges to deal with. But in terms of infrastructure comparison, it's an apples to apples comparison if you establish that with Bangladesh. We cannot compare ourselves at the moment to Malaysia or certainly not Singapore or any of the other countries. Countries in Southeast Asia, the Philippines and Vietnam have very different structures, very different social dynamics. Vietnam, for example, did not even report a single case until a couple of weeks ago. I find that astounding. And I've lived and worked in Vietnam. They have a very good public health structure. But if they were effective, I haven't seen a study published just yet. I look forward to seeing it and finding out exactly what they did. For the time being, Bangladesh is a good template to use.
Right. Thank you, sir. Sir, the next question is, how can we reduce the panic caused by COVID-19 amongst our patients in our practices?
Absolutely. The basic template is simple. What I've seen, and I say this as somebody who went to medical school and worked for a little bit in Pakistan, grew up there. We in the medical community in Pakistan, and I say this guardedly, please do not be offended. We tend to take the doctor knows best approach, where we are beyond reproach and what we say is gospel truth. Patients believe that too. So if you're with somebody who has anxiety or concerns related to COVID-19, please do not stray from the scientific facts. Please do not provide false assurances. Please do not overhype or overstate anything, because they will find out contradictory facts. They will go online. They will go to the University of Google to find out, and they will get WhatsApp messages that will contradict what you say. State only the facts, the known facts, the corroborated facts about the universal precautions. Yes, everyone is at risk. Don't let your guard down. Wash your hands. Keep your distance. Wear a mask. Desanitize, decontaminate your home as best as possible. Limit the number of people that come and go to your house. That applies to domestic help. That applies to everybody that pretty much gets up and visits each other unannounced in Pakistan all the time. That applies to relatives. Be careful about the circle around you, as well as protecting the old and the frail, the elderly, the parents, the siblings around you, because their health depends on how well you contain your bubble around you. That is the only reassurance that we can realistically provide. Beyond that, when people have questions about, well, what's the treatment available in Pakistan and when can we have a vaccine? God alone knows. There are not enough ventilators in Pakistan. And, despite our best efforts, there will never be. That is a fact. So all we can do is tell people, do your best to avoid getting to the point that you end up on a ventilator, because you will not like it.
Thank you, sir. That's very true. So the next question is, what are your thoughts on smart lockdown? Is smart lockdown helping us, in your opinion?
This is my personal assessment and my personal opinion, and I have talked to other public health colleagues in the United States as well. Smart lockdowns work only when they are actively supported by the people that you are putting in lockdown, and that can only happen if you've informed them about why it is important for your locality, your neighborhood, your district to be in a lockdown mode, whereas the neighboring district is not. that affects their lives, that affects their livelihood, that affects their food chain, that affects their utilities, etc. All those reassurances have to be provided by the federal or state government or local government. And unless people first receive assurances that they're going to receive food and rations in their home, they don't have to leave for 14 days or 9 days or 10 days. They will receive the medication that a lot of them are dependent on. If somebody needs insulin, you have to get them the insulin. You can't expect them to come out of the lockdown area and go all around town trying to find it and then go back in. That's not going to happen on its own. Smart lockdowns have worked in countries where those structures and systems have been taken care of first. They don't happen and they don't work where the announcement is made and suddenly you have police checkpoints and paramilitary forces just cordoning off an area and saying, sorry, you guys are in lockdown because you had too many COVID-19 cases. That leads to a backlash against public health. That leads to a violation of all prescribed SOPs and procedures. That does not help public health. And believe me, public health officials in the United States have been vilified unjustly whenever those lockdowns have been implemented in some parts without taking care of all those things. So yes, I'm putting the US in the same basket. Pakistan will have a challenge to deal with. I really have no easy answers, but it will require the entire federal cabinet and provincial cabinets getting together, all ministries, all portfolios, to determine how to provide support to a particular district or an area where a lockdown has occurred.
Right. Thank you, sir. Sir, the next question is a follow-up on the schools question that I asked earlier. So Dr. Amreen Malik is asking whether it would be a better way to open schools like a partial class opening, and then the class having 2 or 3 sessions per week, and then the rest should be online. Like, do you have a suggestion on how they should open it?
Absolutely. So in the United States, the recommendation that we've made here in St. Louis there are 8 school districts, easily about 200,000 students put together. The recommendation that we've made is that they have a tiered approach. So in the first tier, we would begin with what you've just described, have classes on alternate days or alternate sessions so that you lessen the number of students in each individual class. You place the tables and desks 6 feet apart from each other. You institute strict protocols where there is no recess, there is no lunch break. Everybody eats at their table. They don't move around. They don't share pencils. They keep their masks on. The tier 2 approach is when things get tricky. Now, this, by the way, the tier 1 is easier said than done. Controlling a bunch of toddlers or 3rd or 4th grade kids, getting them to wear their mask properly and not take it off and expose their nose, that's all very difficult to do. What we recommended to these guys, I know this may sound like overkill, is that if they're going to do that, they should have plexiglass shields around each table as well. School will seem very strange. In Pakistan, that's impossible to do. You can have staggered sessions, yes, but the chances of exposure to staff will not lessen because you will still have the same number of staff, the administrative, the janitorial, the custodial staff coming in, the teachers coming in and out of the classroom. Yes, you can mitigate some risk, but not all risk, and it is an increment. So, if you're comfortable with being able to manage, and this is a decision for principals and school officials to make, not for public health officials, if you're comfortable with that, sure, that is worth trying. It has been tried. It is ongoing in the United States. But once again, the cautionary tale that I narrated out of Georgia was one where when kids were inside the class, they were all seated separately. They were all asked to wear masks. As soon as they exited into the hallway to go to another room or lab or class, they took their masks off. They high-fived each other. They hung out together. And sure enough, 5 days later, 100 students and 36 staff came down with COVID. So one breach in protocol can cause a catastrophe.
Yes, very true, sir. Sir, the next question is, do you believe that regular flu vaccine could somehow help contain or provide some benefit in coronavirus patients?
Those magic words, I don't know. And I say that only because we simply are not there yet. And if and when a coronavirus vaccine becomes available, we will still be dealing with a seasonal flu. So yes, both vaccines will need to be taken. God knows in how many doses or whether it'll be seasonal. We simply don't know. We're not there yet. What we do know is that anyone who is particularly at risk because of influenza or who worries about their respiratory health or cardiac health or overall health, diabetics, the chronic disease patients every flu season, and they're eager to get the flu vax, are also the people most vulnerable to COVID. And so as far as a safe, effective, and readily available COVID vaccine, it cannot get here soon enough. As for whether getting a flu vaccine will afford some degree of protection, I simply don't have enough information to answer that question. There are much smarter people listening and watching that might be able to comment on that.
Right. Thank you. Sir, the next question is a follow-up similar to the school's question. So, what do you think of Pakistan opening up the country, especially since the cases were decreasing? So, this especially refers to, for example, businesses that started failing and now are desperate to open up. What would be your recommendations for them?
So, in that sense, Pakistan and the United States are not very different. It was a political / economic decision. Businesses were suffering. People were losing their livelihood, losing their daily wages, at risk of not being able to pay their mortgages or rents, etc. And so the pressure mounted to such a point that that decision had to be made. And in Pakistan, that decision was not made lightly. What compounded Pakistan's problems even further was that Eid al-Fitr and Eid al-Adha fell within this, particularly Eid al-Fitr. And I remember that there was tremendous pressure on the government to ease the lockdown, to allow people to travel and be with family. Talking to people about staying away from family in the middle of Eid al-Fitr celebrations is a lost cause to begin with, no matter how many public health facts you can dump on them. So I feel as a public health professional, if I were standing next to the prime minister and he said, well, what do you think? And I would tell him, listen, here are the facts. Here's what's going to happen. I can tell you based on the mathematical projections and the models that we have. But the decision is yours to make, because there are a lot more factors for you to consider as the leader of the country than the opinion of just one public health official. And that is unfortunately what it was. Within the United States, having said that, Dr. Fauci said just the other day that what we need is a nationwide lockdown for 2 weeks. All states, all cities, no interstate travel, no international travel. That is a tremendous undertaking. I don't think that's ever going to happen. We simply don't have the willpower or the political structure or will behind it. But that is exactly what it will take. Pakistan did that, but you also have to take your foot off the pedal because people get exhausted, your economy tanks. So we will see this waxing and waning effect going on for quite some time. I think there's another lockdown that is likely to happen in Pakistan based on current trends, regrettably. May Allah have mercy on us.
Okay, sir. So the next question is, in terms of resource management, which country has performed the worst in containing COVID-19? And similarly, which country has performed the best?
For me, that's an easy question, honestly. Look no further than the United States in terms of a country that had everything they could ask for, all the resources, the personnel, more money than they could count. And yet here we are, 162,000 people dead and counting. 2,000 Americans die every single day of COVID-19 as of today. It was 1,000 a day as of a week ago. So that tells you something. That's the worst. The best is New Zealand. And once again, New Zealand is an island, smaller population. It was very easy for them to do so. But the political leadership and the public health leadership were on the same page. There was no sunlight between them in terms of what needed to be done. All political considerations were set aside, and public health and scientific evidence was followed in terms of imposing decisions, even harsh ones, to shut down their economy and impose lockdowns. The result is that they have gone 100 days today without a single COVID-19 case.
Yeah, I think New Zealand has been amazing. Sir, so the next question is, why is insomnia more common after having COVID-19?
I don't know. That is a clinical question. I would defer to my esteemed colleagues who actually practice clinical medicine for that. Regrettably, I don't have enough information to answer it.
That's fine, sir. Thank you for that. So what's your input about social gatherings, as in the number of people that are recommended to gather and practice distance measures? So the number of people in your...
So all we have are guidelines, right? It depends on a number of factors. What is the size of the room? Is it well ventilated? Are the windows open? If it's in a closed air conditioning or HVAC unit circulation, as often in Western countries, then the ambient air is being circulated in and out. Is there a UV light filter installed in the HVAC unit? Have all these people, however they might be inside the room, being practicing universal precautions? But all we have are broad guidelines. So currently, for example, in the St. Louis area, we've recommended no more than 10 people be in the same room at the same time. And if they are there, that all of them wear masks and that the room be well ventilated as opposed to being closed. And of course, take precautions with the air conditioning and the circulation of ambient air. There was an excellent study, actually not a study, but a case report, I think, from South Korea that talked about one individual being able to spread the infection because they were seated next to an air conditioning intake vent, and people further down that corridor served by the same vent ending up positive 5 days later. Now, how efficient is that transmission? Does that happen in every scenario? Is it replicable? I really don't know. More studies will have to be done to demonstrate it, but it was alarming enough in terms of how the air is circulating. So it's not just a question of how many people, how far apart are they seated, are all of them wearing masks, have all of them practiced the universal precautions of hand washing, hand sanitization, have they been careful, who else have they been in contact with? It's all those things put together.
Right. Thank you so much for that, sir. Sir, I believe this is the last question so far. So once the vaccine is available, how do you foresee public health issues with developing a system for vaccine distribution?
That is an excellent question. Pakistan, I'm very proud to say, has a very good infrastructure in place for vaccine administration and distribution. And guess what I'm talking about? It is the polio eradication program. We already have a trained workforce of people available. More importantly, they know the territory that they work in. They know the neighborhoods, they know the streets, they know the people, the popular opinion leaders, the mosques, the religious leaders. And we have spent, I say this with great pride as a Pakistani, the better part of 30 to 35 years building up that program. That is a valuable asset for us. So let's say we had a vaccine available today that was affordable. We had 220 million doses or more available to us. What it would take is making sure that the same workforce used the same cold chain custody to keep vaccine supplies safe, go around, administer the dosage necessary, whether it's one dose today and another one a month later. We don't know yet what the schedule will be, but more importantly, documenting the details of the individuals that have received the vaccine, because that's the invaluable information that's going to help us determine how much of our population is covered, how much, dare I say it, herd immunity we have built up over time. I know that's a dirty word right now, but that will be the ideal scenario. Kudos to the National Institutes of Health and provincial health officials in how they've gone about maintaining that workforce. I know polio is still an issue. We still have one or two cases of wild polio transmitted every now and then, but that workforce is there. We cannot afford to lose it. I'll tell you this much: compared to Pakistan, the United States does not have that trained workforce available because we don't deal with the EPI. We simply assume that everybody doesn't have to be threatened by things like polio, etc. And we have a very active and loud anti-vaccine lobby because freedom, once again, the joys of it anyway. We would have to go back to the drawing board and figure out how we would distribute vaccine and administer it to 330 million people. And yes, there are ways to do it. I'm absolutely confident we'll be able to do it very quickly. But currently, as things stand, Pakistan is in very good shape to do that.
And that's very true. Sir, there is another question. Do you think that public places can be designed with a positive and negative pressure in place? Like schools, do you think that would help?
Yes, that would help. However, there is a cost factor associated with it. And so let's be clear about what we understand by the term negative pressure systems. Negative pressure systems are designed to be installed in tuberculosis clinics, for example. That's the best example I can cite you, where you have a separate examination room with a negative pressure system built into the ceiling so that droplet infection is minimized. Doing that in schools is going to be challenging because you don't really have just the patient and the doctor or the nurse going into the room. You have 20, 30, 50 students, one or two teachers, other staff coming and going in and out. And the seal on the negative pressure system is not going to be sustainable. That's what a negative pressure system is. A negative pressure system is not installing exhaust fans on opposite ends of the room and creating some sort of airflow. That will not help. Yes, that will circulate air possibly in and out of the room, which is better than not doing it. But as far as how much mitigation it provides, the evidence remains unclear at best. And so it is an expensive and probably an impractical idea to consider negative pressure systems for classrooms.
Right. All right, sir. Sir, the next question is, if a second wave of COVID-19 occurs in Pakistan, what will be the most reasonable course of action to take?
The threshold for a second wave is one that has to be defined carefully, and it is different for each country. Pakistan, on current evidence, is not out of the first wave. So it is much too early, I think, to be talking about a second wave occurring. We are simply on the downward ebb and going into the plateau of the first wave. So it's not out of the realm of possibility that a second wave would occur at some point in time. But for that to happen, we would need to reach a place where cases plateau out or decrease consistently over time to a point where we think, we're in the North Korea situation. We only have 1 or 2 cases occurring every day, or even 50 cases nationwide occurring every day. And then we suddenly start seeing 500, 600 cases a day. We are quite some time away from that spot on the graph. It is not even appearing right now. At the moment, we're still in that first wave. So at the moment, all we can do is intensify ongoing efforts and try to make sure that we keep an eye on those trend lines, because if things start going south any further, there will be a second lockdown. And yes, it will have to be a countrywide lockdown, regrettably.
Right. Okay. All right. Sir, another question. So as you know, most of Pakistan's population lives in rural areas, and a lot of guidelines that have been developed internationally, especially, and maybe sometimes nationally, are for urban areas.
Right.
So what would be your tip for somebody who's living in a rural area, even a physician working in a rural area? What would you recommend that they do, the minimal that they can do to maybe prevent the spread?
Absolutely. So in the United States, the focus, for example, has been on urban areas, and that's where most of the population lives. The rural areas have been hard hit by COVID as well. That may seem strange. That came a little later than we thought it would. But the virus has spread to rural areas. Now, if you think of rural areas, you have distance, you have relative geographical isolation. You would think it would be easier for people living in rural areas to socially distance themselves and avoid unnecessary contact. You would think that it would be easier for people living in rural areas or villages or small towns to practice all the precautions that we've preached. The reality is it is not. They depend on their livelihood for human contact, on human contact. And so for them to be able to distance themselves is an unrealistic expectation. You do have several family members cloistered together in a relatively small footprint in terms of the dwelling or residential dwelling. So that increases the risk. People do need to step out to make their livelihood, to go to the market, to purchase supplies, etc. Kids do need to go to school. So all of those points of introducing infection into the household, those portals are still open. For any physician working in a rural area, the most important aspect of this is prevention. That is the only thing they can emphasize. And there are some inherent advantages to people in rural areas being able to practice universal precautions if they tried to, if they really put their minds to it. And if the social structure around them lends itself to doing that. I really, and this comes from my heart, the pictures of people lining up to get food, rotis from a tandoor, or a langar, a free distribution point at some point in time. I remember looking at that in Pakistan in the middle of the lockdown, the initial lockdown, and thinking, how do you talk to people like that who, you're essentially asking them to make a choice between public health prevention measures and the hunger pangs that they or their children at home are feeling. That is a losing proposition every single time. Public health loses out, and justifiably so. So back to the point about the rural colleague, yes, you will be resource constrained. Prevention is the only tool in your box. Use it wisely, use it over and over again, use it multiple times, use visual aids to educate people, and reiterate it to the children in the house and the female in the house, the matriarch. That is where the difference will be made.
Sir, so the next question is, and they just keep on coming.
No worries, I have time.
All right. So Dr. Misbah Murtaza is asking, should we consider asymptomatic and symptomatic cases equally morbid?
That is a difficult question to ask. We know that asymptomatic individuals can transmit infection. I'll give you one example from 2 weeks ago. So I had every staff member, including IT, security, custodial, janitorial, and clinical, and admin, tested at our health center, just as a point-in-time test. We used a 15-minute rapid test. 6 individuals, all of them asymptomatic, tested positive. Now, for the last 5 months rather, ever since the initial crisis began, we have been actively screening individuals twice, even 3 times a day when they come into the health center to work. A temperature check, a history check, wash your hands, sanitize, have a sticker on you that says you had your temperature checked. If they step out for lunch and they return, it's done again. Despite that, 6 people were asymptomatic, and I really have no idea how long they might have been walking around, possibly spreading the disease. This is just one of those conundrums. As for the clinical course or the morbidity differences related to symptomatic and asymptomatic people, that is a clinical question I would have to defer to much smarter colleagues to answer. But for us, on the prevention side, it is a very, very difficult equation to use. Some places in the United States have instituted mandatory rapid testing every single day. When you come in, you get an NP swab, you wait in a separate room, or you wait outside in the parking lot in your car until you receive a cell phone message that says you're cleared to come in to work that day. But even with those things in mind, but even with those strict procedures in place, people still end up testing positive because of social contacts and what they do outside. So they could be negative one day and be symptomatic or asymptomatic and positive the other day.
Sir, and this is, I think, the question that everybody seems to be asking these days. Will herd immunity be a reality in Pakistan?
Yes, that is a difficult question to answer. So let's be clear about what herd immunity is and more importantly, what it is not. So the term herd immunity, regrettably, has been politicized and used by politicians of all variety, including the fearless leader of the United States, as well as his long-lost cousin in the United Kingdom, to spread myths and political dogma about COVID-19. And herd immunity, with COVID-19 right now basically implies that enough people have contracted, a lot of people would have to contract the virus and recover sufficiently from it or die from it before we get to a point that we could say, well, now that everybody's exposed, we can all get on with our lives. That is not what herd immunity is. Herd immunity is a scientific term which pertains to a well-studied, well-documented immunogenic process that confers protection, antibodies, etc., either through a vaccine or a sufficient recovery from illness without a vaccine, and immunity that lasts a long time. We know from people that have recovered from COVID-19 that their antibody levels begin to virtually disappear at 3 or 4 months post-infection, resolution of symptoms. So for a place like Pakistan, I think it's premature, if not unrealistic, to talk about herd immunity at the moment. Once we have a safe, effective, readily available, and affordable vaccine, once we're able to vaccinate 80% of our population, we'll get to a point where we can say, yeah, you know what, we have enough people immunized with good antibody levels. We're probably okay herd immunity wise, but that we are a long way away from that.
Right. And another question, sir, since we do have people who have been infected, there are often times when people who have been infected think that they do not need to follow the same preventative measures that other people are doing. So, what are your suggestions for them?
If somebody is infected, excuse me, if somebody is infected, they need to absolutely isolate themselves. Of course, recover safely, hopefully, but keep an eye on their signs and symptoms. If their respiratory distress worsens, if they have difficulty breathing, etc., of course, they need to seek help. But I think for people that have been infected and have recovered, there seems to be a myth imparting on them a false sense of security about the fact that they contracted the infection, they contracted the virus, they became sick, they recovered, and they now are immune to this. They don't need to practice universal precautions. That is absolutely wrong. We know that immunity wanes in 3 months or less. So no, you're not protected, and you're not doing anybody else any favors either around you, particularly the old, the frail, the people living with chronic disease conditions, if you're not practicing universal precautions, which means you have to wear a mask. And yes, genius, you still have to wash your hands. You still have to maintain your distance. And God forbid, if you're reinfected, there are case reports where people who are reinfected end up with symptoms that are more symptoms that are more severe. So it's one of those great unknowns. There is a lot yet to be learned about that, but people dropping their guard just because they've recovered from COVID-19, God bless them, that is not the way to go about it. That is a very dangerous assumption.
Thank you so much, sir. I think this was one of my favorite question answer.
Oh, you're being very kind.
We're out of questions now. But this was an amazing session, definitely very insightful for me and definitely for the participants watching as well. I would like to thank you from myself and on the behalf of VFP for joining us from so far away and for giving us your very, very valuable time. Thank you, sir.
Thank you so much. It has been an honor. Thank you so much.
Thank you, sir.
Khud Hafiz.
Hafiz. I am now pleased to announce our second speaker for tonight, Dr. Ahmed Abdullah, who is an assistant professor at Islamabad Medical and Dental College, a consultant family physician at Agha Khan Health Services, a panel medical officer for Pakistan Broadcasting Corporation, and a clinical administrator at Rotary Shifa Community Health Center. Dr. Abdullah received his MPBS degree from Nishta Medical College and completed his master's in International Public Health at Armed Forces Postgraduate Medical Institute. He did his MCPS in family medicine from College of Physicians and Surgeons in Pakistan. He has a special interest in healthcare management, HRH management, public health, family medicine, social sciences, infectious diseases, qualitative and quantitative research, health administration, and conflict resolution. He has previously served as hospital medical superintendent at Al Hissan Hospital, specialist in family medicine at MOH KSA Riyadh City, as a senior instructor of community and family medicine at Shifa College of Medicine, as well as faculty of MBA Health Services Management at Shifa Tamir Millet University. Please allow me to welcome Dr. Ahmed Abdullah to share his insight on identifying and managing COVID in resource-limited settings.
Assalamu alaikum ji. Thank you for having me. Where this session is basically going to be me sharing my experiences of working in resource limited conditions with COVID-19 during the ongoing outbreak, if I must say. And sometimes we won't be going into the gory scientific details, and we'll try to keep it interactive and lively. But this is an experience sharing session, and I'll share with you some of my experiences. I was here for the previous session, and I saw that Dr. Saab was talking about the idea that America is performing poorly, especially as compared to Pakistan. There are many reasons for this. But one particular reason that I think that might be working is that in the Western world, we people have a lot of pressure for litigation, especially doctors practicing. So in Pakistan, we have an open playing field, and we can use any medicine without any fear of litigation, and that sense of trial and error has helped us some in a way, and has created problems in other ways as well. But that is one point, and then there are other reasons for us performing better there compared to many other countries in the world. So if we could jump on to the presentation, I think Maham, you have it with you.
Yes, sir.
Right. So we'll be talking about working with COVID in resource limited settings. So the first slide of this presentation, uh, the next one, would shows you a figure of a bear sitting lonely inside his cage in a zoo. So and the quote says, the idea that some lives matter less is the root of all that is wrong with the world. This is from one of my favorite authors, Paul Farmer. And I think that you know this is actually what happens all around the world, that because some lives matter less, so they require less care, and then they end up having poorer outcomes. So poverty, not just about resources, but poverty of opportunity is a serious issue that uh, the world needs to look into. So on the next slide, we'll be going right. So in the next slide, we'll be talking about an overview of what we'll be talking about. We have some background, some myths and fallacies, fears, diagnostic approach, therapeutic options, some non-pharmacological interventions, red flags that we picked up on the way, mental health issues, and a very important aspect of this pandemic is the counseling part. Uh, so on the next slide, we see that. So this is a basic introduction of the coronavirus, where we know that it's from the coronavirus family, and like so many other infectious diseases, we got it from animals, like malaria, like tuberculosis, and this is new for us, for our generation, but this has happened many times in the past. Uh, we It happened 3 generations ago. That's why there was no one to tell us what to do, and this is how we reacted. So it is initially it was presented as a pneumonia of unknown cause from Wuhan, China, on 31st December 2019, and it was declared a public health emergency uh, on the 30th of January 2020. Uh, Moving on to the next slide, we see that we already know that the spread is when people cough or exhale, and their droplets are transmitted to other people, or they land on surfaces that we might touch and then touch our face or nose or eyes later on. Touching contaminated fomites, and if you're standing too close to people who are already infected with you might catch that from breathing. Uh, if you're running in a park or walking, and someone's running in front of you, you might catch it from there, and then it spreads like common flu. So any place that has a high prevalence of respiratory illnesses uh, would be a nice place for COVID to flourish. Most infected people suffer from mild symptoms and recover, but more serious patients often require hospital admission and are at a greater threat to having a poorer outcome. People over 40, people with weakened immune systems. So the next slide talks about how historically pandemics and diseases have influenced the human history. Uh, there are still many references that we use in everyday life that come from pandemics. If you remember the nursery rhyme "Ring Around the Roses," which is actually a reference towards the Black Death or plague in Europe, or when we lovingly use the term quacks to describe untrained medical professionals, we're talking about the people who had those strange masks on while they were treating people with bubonic plague. So history has been influenced by diseases and outbreaks in the past. The Probably the largest epidemic known to mankind was the smallpox epidemic. Another important feature to remember over here is that when one disease outbreak occurs, it increases the chances of other outbreaks to occur as well. So when the world was busy handling, not the world, when Americans were busy handling their measles epidemic after the First World War ended, they were struck by the swine flu epidemic, and the rest is history. So moving on to the next slide, this again, like many other things, is a zoonotic disease, and zoonotic diseases are transmitted from animals to people. Uh, so the point is that as long as diseases which have hosts other than humans, it is very difficult to get rid of the reservoir, because even if you get rid of the disease in all of humans, you will still have animal reservoirs. And as long as people are interacting with animals, someone somewhere will get it and transmit it to other humans as well. Uh, this is nothing new. People have been contracting diseases from animals. We know about malaria, we know about tuberculosis, we know about HIV/AIDS. This virus was an animal virus, but once it entered the human bodies and the human populations, it started acting like a human virus. So now the COVID we're concerned with is a human virus, but our pets, the animals that share space with us, that we interact with, will become a reservoir for this in the future, even if we manage to control it in human populations. So the next slide talks about the signs and symptoms of COVID-19, and this is these are things are mostly known to people by now. So people have fever, fatigue, they have deranged kidney functions, they might have diarrhea, they might have sneezing, a runny nose, sore throat, dry cough, shortness of breath. But we've seen productive cough as well. So because this is a developing conditions, and we're seeing patients, uh, there are other presentations as well. They will be included uh, once new guidelines keep on appearing and more research, which is ongoing, is being done. And strangely, this disease causes problems in the circulatory system with a decrease in white blood cells, and also sometimes in platelets. So this data on the next slide talks about the common symptoms. That this was probably the first study that came out of China upon 138 patients and their clinical characteristics. So in this, you can see that fever, fatigue, dry cough, loss of appetite, body aches, dyspnea, expectoration, pharyngitis, diarrhea, nausea, vertigo, headache, vomiting, abdominal pain. All of these were the common symptoms, and similar results have since been replicated in other studies as well. We talk about the investigations carried out in the next slide, where many people have had significant lymphopenia. A large number had prolonged prothrombin time, elevated LDH levels, and they showed bilateral patchy shadows and ground glass opacities when a CT chest was done. And most of this has been further strengthened by further research and evidence. The treatment options they initially used, which are on the next slide, included antiviral drugs, glucocorticoid therapies. They use antibiotics like moxifloxacin, ceftriaxone, azithromycin. Oxygen inhalation was required in a large number of hospitalized patients. They even went through with renal transplant for 2 patients because conditions like this take people into multi-organ failure, and so if places where they have resources, they end up with the highest possible intervention. 10.9% people had non-invasive ventilation, invasive mechanical ventilation in 12% people, and extracorporeal membrane oxygenation in 2.9 people. This particular study did not use chloroquine phosphate initially, because this is one of the first studies. So next, we'll be talking about the prevention, and most of the things regarding the prevention are already known to the audience, I am sure. On the next slide, we know that it is an airborne virus, and it is spread from when people cough or from wild animals or through social contact. And we know the basic symptoms. So regularly washing your hands, wearing masks in public, avoiding crowded places, wearing a mask if you're ill, avoiding going out, avoiding contact with animals. All of these things talk about prevention. But in resource limited settings, prevention becomes a difficult task to achieve. In the next slide shows us a picture from a slum area in Islamabad, and this picture is, I suppose, more important than the words I'm using. How can we handle these kinds of crowds? How do we tell people with 8 children living in a one-room home to handle each other's matters while being socially distant? How do you tell a mother of 10 to stay away from or manage a distance? They don't have that kind of space where they're living in. So social distancing, even if you enforce that when people go out, which we haven't though, it's a difficult task to ask people to be socially distant when they're already crowded up in a jam-packed place and have a large population inside a small dwelling. The next slide talks about hand hygiene. So we tell people to wash their hands for 20 seconds using soap and water regularly. What do you do in a place when there is no regular supply of water? They might have soap, but this is how many people in Pakistan gather water from various water sources, because around 70% of the people in Pakistan do not have access to clean drinking water. We're not just talking about the urban areas when we're talking about Pakistan. An important thing to remember is that a large proportion of people still reside in villages, and their knowledge level, the level of their awareness isn't too good in that regard. So the next one is respiratory hygiene. This is a relatively newer picture from this Eid al-Adha, and you can see that a lot of people and animals, warm-blooded animals, that could become potential carriers as well. That is why we were discussing the idea of zoonosis previously in some detail. So recently, many people and animals, a lot of these people in this picture are wearing masks, some of them properly, most of them improperly. Plus, the idea of hand hygiene in a place like this becomes, uh, ununderstandable for the people working in places like this, or people visiting places like these. Lastly, we must talk about our exposure and the awareness. uh, on the next slide, this is a picture I recently took in a place in Islamabad, and it talks about a warm drink prepared specially to fight the COVID-19, the SARS-CoV-2 virus, and apparently it kills the virus within 12 hours. And while you're there to get your kava, you can get yourself circumcised as well. And if you don't have a job, they have a job opening for you as well. So the point is, this is just a small example of what we as healthcare providers have been dealing with. It's not just the disease or the poor outcomes or the large number of patients. It's this kind of ignorance and claims without any sound evidence in the background, which tell people to do otherwise. And because these claims are catchy, because they sound nice, because they're not too complicated to understand. When we start teaching people of how a virus they cannot see can be transmitted to things they can carry home, by sitting close to someone, by simply talking to someone without a mask, these things become difficult to understand. But comparatively, if someone tells them to have a warm drink and they can kill the virus in 12 hours, why not? It's nothing complicated to understand. There's no scientific evidence that you will have to assess before believing the fact that drinking this kava would cure your COVID-19 within a matter of hours. And there are many other examples which we are going to discuss as we move on. So this part is for my colleagues who are practicing medicine and who have been practicing medicine. These were the common complaints that patients presented to us with. On the next slide, you can see that in the history, common presenting complaints included fever, cough, mostly dry but sometimes productive, body aches and headaches, flu-like symptoms, generalized weakness and lethargy, loss of smell and taste, diarrhea, nausea and vomiting, breathing difficulty, urinary symptoms, vertigo. Now, when you're asking about all of these symptoms, you should ask about the duration of exposure and the duration of symptoms. If the person smokes or not, is he exposed to a situation where he's has exposure to smoke. It could be cigarette smoke, it could be smoke from fossil fuels. Do people have pre-existing comorbid conditions like diabetes, hypertension, ischemic heart disease? One thing that we need to consider working in places like Pakistan are the chronic infectious diseases that people have. So these comorbids do not, we should not only include the chronic, the non-communicable diseases in the comorbids. We should also include conditions like tuberculosis, like hepatitis B and C, which are prevalent in our part of the world, and they're complicated. So people face these conditions as well, and a COVID-19 co-infection could worsen the outcomes of their pre-existing infectious diseases as well. And then occupational history is really important, because if someone's a taxi driver and he's suffering from COVID, you might have to enforce uh, him to sit at home and leave his livelihood, because if he continues to work being a taxi driver and carrying COVID, he would be a super spreader. Or someone who's a bank teller and he's handling people's money and he gets COVID positive, or a guy working in a petrol pump who's handing money over to people, or someone who's cooking, uh, someone who's a tailor, anyone who's in public service could become a super spreader. And we need to be careful of these people, and we need to counsel them properly. So when you're examining a patient with the things that we've discussed in the history, on the next slide, the first thing you'd go for would be their temperature, would be their pulse rate, their oxygen saturation. So it's really handy to have a finger pulse oximeter available whenever you're practicing, or if you're visiting people at home, or if you're caring for someone at home under under a doctor's advice. So temperature monitoring is really important. It gives us a lot of information of how well the immune response is working. If that person might have a coexisting or a superimposed bacterial infection, they might have any other conditions. Their pulse rate is also important, which you can check through the pulse oximeter. Many people have tachycardia when they have COVID. Some of them because of COVID, some of them because of the anxiety caused by COVID. And then we need to look at people's respiratory rates, their blood pressures. We've seen people with comorbidities having higher blood pressures, and then we've seen people without comorbidities having lower blood pressures and hypotension, and all the effects that come with it. Blood sugar levels should be monitored as well. Many people suffer from hypoglycemic episodes, especially we've seen diabetics suffering from hypoglycemic episodes, and we've had to manage them. And once those episodes were managed, the people responded in a better fashion. Always auscultate the chest of your patients, and then you can have a throat and eye exam if possible, if you're protected well enough to let the patient open up his throat. Although we've seen people, doctors and nurses and all sorts of health providers working in poorly protected circumstances. So the basic investigations that which are a bit cheaper and can be done easily on the next slide are a blood complete picture, a chest x-ray, liver function tests, LDH, PT, APTT, urinary. You could get a SARS-CoV PCR, and then you could get COVID-19 antibodies for people you think have had the virus previously, or for the purpose of research. We at my clinic, we arranged some free antibody tests for people coming in, not just patients, attendants, and medical representatives from various pharma companies. So we had 31 patients who gave in their samples for a COVID-19 antibody test, and out of those 31, 16 had a positive antibody, while 15 had negative antibodies. Most of these people, so this is more than half of the people had COVID in the past 2 or 3 months, and most of these people had remained asymptomatic. Almost all of the pharma reps had been COVID positive in the past. That is probably because they had to work during the outbreak season, and most of them had to wait in the waiting areas of clinics and hospitals, and they somehow picked up the virus from there. I've intentionally not included things like the HRCT on this slide, or the D dimers, or all of those, the interleukin levels, because all of these tests become relevant when one requires to be hospitalized, and these tests are more relevant for people who need critical care. On an OPD basis, we could do well with the tests that I've mentioned. These are cheaper. Even the PCR is available on a cheaper rate. It's actually free in government setups, but people were really scared of going to government hospitals when the outbreak was on its full bloom. The treatment options that we used to treat this condition were, we used various antibiotics, which are on the next slide. We used antibiotics like azithromycin, moxifloxacin, doxycycline, levofloxacin, ceftriaxone. I had pretty good results with doxycycline. Sometimes we combine doxycycline with levofloxacin. We were previously using these antibiotics to handle atypical infections in elderly patients, and they showed their worth during the COVID outbreak as well. We generously used a lot of steroids. We used injectable dexamethasone. We used oral prednisolone. Again, from the start of my talk, I talked about the fact that in Pakistan, because we don't have that fear of litigation while practicing, we have an open playing field to play around with medicines and see their results firsthand with the patients. I know this is not too scientific. I know this is not evidence. Evidence and guidelines require a large sample size, and clinical trials are a tricky matter. They're complicated, and they need a lot of time and resources and efforts. But practicing in resource poor settings gives you that advantage that you have an open playing field. Next, we used antipyretics and anti-inflammatory agents. Mucolytics had pretty good results, where we used things like acetylcysteine to get that thick mucus out of people. Antihistamines played some symptomatic role. We used antitussive, a lot of herbal remedies and syrups like the ivy leaf syrups have been used during the past few days to handle COVID. Leukotriene inhibitors, which include montelukast, were generously used during the outbreak. We also tried anti-malarials, and we also used IV fluids. Now, one thing that I picked up while working with patients was that the sooner you relieve the symptoms, the better chances that the person's immunity would take up the matter and handle it itself. So anyone with pain, relieve their pain. Anyone with diarrhea, handle their diarrhea. Anyone who's dehydrated, handle their dehydration. Anyone who has aches and pains, handle their pain. Once their symptoms are relieved, they will start improving in a day or two. So at the start of this epidemic, when we had not experienced this virus, we were much more scared. But now when we've managed many patients with it, that fear has been alleviated a bit. So the next slide talks about other conditions that we need to look for or that might mimic COVID-19 in our settings, especially in Pakistan. So this season, the summers or the rainy season already brings with it typhoid fever. And we also have dengue fever coming in. Some people present with common flu and other respiratory conditions. We have people with tuberculosis whose many incidental tuberculosis findings happened during these days because we were getting more chest x-rays done because of COVID. So we picked up a lot of TB because of that as well. And then general anxiety disorders. Many people who otherwise were symptom free or did not have any symptoms, because they were so exposed to bad news over the mainstream media and the social media, they presented with general anxiety disorders, panic attacks, uh, episodes of insomnia, paranoias, and those had to be handled alongside the physical symptoms. Plus, we already know that psychiatric conditions give rise to psychosomatic symptoms in the body. So, someone who has a psychological situation might actually be feeling physical symptoms, or might actually be having some physical symptoms of dyspepsia or insomnia or body aches or things like that. So moving on to the next slide, the red flags and when to refer patients from an OPD setting to the hospital setting. When people are developing breathing difficulty, when someone is following up and they have falling oxygen levels from their previous visit, when people have persistent cough and high-grade non-responsive fever that does not respond to any sort of treatment, too much malaise and lethargy, dehydration, anxiety and panic attacks, that's when you need to get focus more on that particular patient. Plus, we need to monitor the other comorbidities, their blood pressures, their blood sugar levels, uh, their serum electrolytes, any cardiac complications. We need to manage and monitor those as well. Uh, the next slide talks about a very important aspect, which are the mental health issues related to the COVID-19 outbreak. So dealing with death and disease is a serious mental health condition. It also challenges the way we view life, the way we perceive things around us, things that are important to us, relationships, and knowing the fact that you could, in these times, you could lose anyone, you could be lost yourself. But then Marcus Aurelius, the philosopher king of Rome, uh, every night when he kissed his children when they were going to bed, he closed his eyes and he imagined the fact and he cherished that moment that there was no guarantee that either him or his children would be awake and alive the next morning. So we should cherish every moment that we have and deal with death respectably and in a dignified way, not only with death and but also with disease. There is a very important saying that says that a life lived in fear is a life half lived. So unnecessary, being fearful and careful are two different things. It is good to be careful, but fear reduces our immunity. The next point is stigma and discrimination. We know that all diseases have been stigmatized, especially diseases that can be spread from one person to another have been stigmatized in the past. Uh, People had leper's bell, where lepers had to, when they were walking into a new place, a town or a village, they had to ring that bell. So everyone knew that the leper was coming in, so they would move away or go inside their houses. We've seen stigma and discrimination related with HIV. I remember reading in a book about the 4-H club, or was it the 5-H club, which talked about in the early days of HIV, they said that homosexuals, Hispanics, Haitians, hemophiliacs, These were the four kinds of people who contracted HIV and they spread it. So in this uh, clubbing, you can see that two nations have been identified as potential people for spreading a disease. So anyone who belongs to Haiti or was a Hispanic would be automatically refused jobs and would be automatically stigmatized for having the increased chances of having HIV. And people with hemophilia who had to have regular blood transfusions were stigmatized in that. Uh, because none of us have seen isolation or quarantine being practiced that it has been practiced in the past few days, loneliness and the mental health conditions associated with it have risen and gained much more importance in the last few days. Then the concept of isolation and quarantine and how one should act when to self-isolate. All of these things were difficult concepts to grasp when the epidemic was out. Anxiety and depression and then triggered pre-existing mental health conditions were also seen in the past few days. There was an increase in domestic violence because people had to stay at home, and apparently they weren't in the habit of interacting that much with their families. So that gave a rise to domestic violence, not just in Pakistan, all around the world. And then financial and occupational problems were also created, which added to people's fears, phobias, and mental health issues. And the idea of uncertainty, not knowing where this is going to end, what the outcome would be, for me, for the world, for my job, for my business, uh, uncertainty in everything, and that obviously has made things worse. So, on the next slide, we'll be talking about the common myths that we encountered during the COVID-19 outbreak. And the first one was that COVID-19 is fake. It doesn't exist. It's fake news. Uh, and this is just pharma companies or doctors making it up to uh, earn more money. Then there were other conspiracy theories, which included the point that it is a man-made virus. Yes, I believe that it is a man-made virus, and it was made by men who are unfair to nature, who treated animals unfairly, with disrespect. And this is what happens when you interact with things you do not understand and powers beyond your control, uh, when you disrespect them. And this is what happens. This is the earth waking up its own immune system, and the real pathogen is probably human beings for destroying Mother Nature. Uh, but people thought that it was a virus made by people in a lab to reduce the population and whatnot. Then people thought that when they go to hospitals, poison would be injected into them, they would be killed, and their organs would be trafficked, or their bodies would be trafficked to other places. And uh, you would get around $35,000 for a single body. Uh, the Americans could do experiments on them. We had myths about organ trafficking, about money for corpses, and then these caused a lot of self-medication. Everyone that came to my clinic, once they had developed symptoms, most people had already started azithromycin or some anti-malarial. They were drinking different kind of laxative, uh, kavas, which made things worse. Because Typhi dot is being used in Pakistan, which is an obsolete test. It is non-specific, and we should use the blood culture and sensitivity test to look for typhoid. Apparently, many people had a positive Typhi dot, and they were actually happy about it because they thought that, oh, good, this is typhoid, not COVID. So, and this is treatable, so we can get this fixed. Then we had market shortages. Every Facebook post or every social media post that talked about the success of a particular drug or a face mask or any instrument or pulse oximeters, we had immediate market shortages of those things, and those things being sold in black, because and this not only happened in Pakistan. I believe this happened all around the world, where things that were made, which a false demand for which was created, were made short in the market instantaneously. And then we had herbal remedies. I always tell my patients a little harmless herbal remedy, something like isparol or green tea, because they can relate to herbal remedies and they're really impressed by some sort of herbal Gharelu totkas. So the next slide talks about counseling and breaking bad news. So I suppose that in these days, counseling is probably the most important aspect of the healthcare provider and the healthcare seeker's relationship. We had to counsel people. It's not easy to tell people that they or their loved one is in a critical condition. They might need hospitalization, especially during a time where the rumors were spreading like wildfire that people are being intentionally killed or poisoned in hospitals. So we had to counsel people. We had to uh, use our contacts in hospitals, talk to people already working in hospitals to handle these people when they get there. Most of the people who went to hospitals, once they were there, they got treated, they got better, and they came back. Were all praise for the people working in a hospital. But until they had been through that positive experience, all of them were afraid of going to the hospitals. Many people said that people walk in the hospital and come back in a coffin, and this made things worse. So whenever breaking bad news is a very important aspect of a doctor's life, not just a doctor, any healthcare provider's life, or someone who's working in the stock market as well, I suppose. And breaking bad news has many protocols. I like this one the best because it's simple, it's easier to remember, and it always reminds me of that dog from Tom and Jerry, Spike. So the Spikes protocol gives you steps of how to break bad news. So the first step is set up an interview and arrange for some privacy. Set up an interview where you can talk to the patient or their family in detail about their condition. You assess the patient's already existing perception about the condition they have. What knowledge do they have about the topic? What do they already know? And what misinformation or correct information they already have. Once you've done that, you obtain the patient's invitation for you to provide them with actual factual evidence, and you give them knowledge and information. A very important point to consider at the point of knowledge transfer is that a good doctor needs to step down to the level of the patient's comprehension and talk in their language. If there's a language barrier. You could ask a translator to be there, but it's always good to speak in the patient's mother tongue, be it Punjabi or Pashto. So while practicing with various people from Pakistan, we get to pick up words from all languages, and which is an important skill to be had by doctors. I suggest that junior doctors start learning Mandarin, because China is going to be a big power in the future. Once you've delivered the knowledge the patient needs, you handle their emotions with empathy. Now, we need to understand the difference between empathy and sympathy over here. And when handling emotions, we need not to become Munna Bhai MBBS. We should stay, we should keep the patients at an arm's length, be respectable. You could offer them a glass of water, you could tap them on the shoulder, you could offer them a tissue if they're crying, but don't hug your patients, because if you get too many emotions into the doctor-patient relationship, that would also cloud your judgment as a technical person. And in the end, once all the bad news has been broken in an empathetic way, you need to strategize and summarize, and make a summary of all the things that have been said, and make a work plan for the future, and then guide the patient accordingly. In the end, some food for thought. One of my favorite persons in the next slide, uh, Marcus Aurelius, and if you've not already read his book Meditations, go and read that book, where he talks about life in general. He was a Stoic, and Stoicism is a beautiful idea. Uh, Many things in it. So he said that do not act as if you were going to live 10,000 years. Death hangs over you. While you live, while it is in your power, be good. Uh, in the end, all of this epidemiology that we've worked up with, this was many important aspects were told to us about epidemiology and disease and hygiene uh, more than 1.5 millennia ago, where the Holy Prophet, on the next slide, where the Holy Prophet said that if you hear of an outbreak of plague in a land, do not enter it. But if the plague breaks out in a place while you are in it, do not leave that place. So this talks about how to handle an outbreak, and it talks about lockdowns and quarantines and not visiting places with disease. Uh, this happened much before we had the germ theory, or we could see the any kind of pathogen, or we knew the modes of transmission of various diseases. So this brings us to the end of my presentation session. What now?
Thank you so much, sir. Thank you for an informative session. I would now, with your permission, like to ask you some questions.
Sure.
Question number 1. Where would you place the COVID-19 pandemic amongst all the other major pandemics in the last century in terms of its impact on society?
I think this is more drastic and more important because it is happening in a time of information. The Spanish flu was called the Spanish flu. It didn't happen in Spain. Spain, all of the rest of the world was coming out of World War One, and all of them were ashamed, or they felt stigmatized to declare that they were undergoing the Spanish flu outbreak. So Spain was a neutral country in the during the World War I. So they were frank and true about the outbreak in their country, and they gave out the true numbers, and then the world said that it's the Spanish flu. So because it is happening, one thing is clear, that this is an ongoing situation. We have not seen the peak of this epidemic. We will see multiple peaks in different parts of the world. Even within countries, we are seeing various areas being affected, one after the other. So this is an ongoing condition. This pandemic, because the world had become a global village before this hit, travel was easier, connectivity was easier, transfer of information was easier. So once that happened, in a disease broke out in a world full of technology, I think the impact that it has had on society has never been experienced by people in the past. So this is probably the biggest pandemic in terms of how it has affected our lives.
Okay, thank you, sir. Another question is, in a resource-limited setting, what is the best way to prevent the spread of COVID-19?
I think the best way uh, is prevention, because treatment, just for an example, every $1 that we spend on cleaning drinking water saves us $9 that we would later spend on treating diseases that we that would have been caused by dirty drinking water. So it's really important that we focus on prevention, but in resource limited settings, providing people masks. Uh, People could use cloth masks which are reusable, and then teaching them how to clean them or how frequently to clean those masks, the cloth masks, because disposable masks are comparatively expensive and their price keeps on fluctuating. So it's a good idea to ask people to wear at least cloth masks when they're going into crowded areas as well. Plus, ask them to keep their hands clean. The problem is that even before this pandemic hit, we had terrible personal etiquette. We have no idea of what personal space is. And we're a very touchy-feely nation. So it's an uphill task where we want to prevent this condition. Again, the precautions are the same: respiratory hygiene, hand hygiene, and avoiding unnecessary crowded places. But and where use things that can be used regularly, or uh, we should implement changes that can be practiced for a long period of time, not changes that would irritate people in a short span of time and they would get rid of them sooner or later.
Thank you, sir. Another question is, do you think we will see a significant rise in cases a week from now due to Eid al-Adha?
Like the previous Dr. Saab said, I don't know. But the thing is that, projections, we will get a rise in, we will constantly get rise after any event where people get together. So we'll get cases here and there. I think the weather is playing some role these days, because it's very humid and it limits the transmission on an aerosol level, the humidity in the air, plus the extreme heat reduces the chances of surface to surface transmission. Having said that, uh, compared to the good few weeks that we've had, we might have a bit more cases uh, once 1 or 2 weeks after Eid al-Adha. Uh, but I'm more afraid of the winters. Winters are coming, Jon
Definitely,
Snow.
definitely, sir. Winter is coming. There's another question. With the current level at which Pakistan is testing, how much more can Pakistan perform testing considering the limited resources?
I think that it was never on the cards to screen massive number of people. We haven't been able to screen massive numbers of people for conditions that are already prevalent. We don't screen large numbers of people for HIV or for hepatitis B or C, which are already, or for TB, which are pre-existing. So we could have never hoped for universal testing or screening in our circumstances. I think the government is doing a pretty decent job, and they've also involved the private sector as well. So continued testing and looking for clusters, and the idea of smart lockdowns, and focusing on smaller, more administrable clusters that we can handle with our limited resources is a good idea, I suppose.
Thank you, sir. There's another question. What has been the biggest setback public service-wise, public health-wise, that doctors have had to face during the pandemic?
I think that working long hours, working with or without personal protective equipment, and working with aggressive people. There are three stages of truth. The first one is that it is ridiculed. The second one is that it is violently opposed. And the third one is that it is accepted as a fact. So the phase of violent opposition that we went through was really hurtful, because we were working for these people, and uh, I don't mind working for people being a thankless job, but when it focuses people's aggression towards us, that really kills it. So that is
Okay.
probably the worst part of handling things like that.
Definitely, sir. There's another question. In hindsight, is there any single practical action that could have been taken to further decrease the spread of COVID?
Uh, I think more. I really feel strongly about the public transportation system in Pakistan, and I think that stricter measures should be enforced. Something good should come out of this. Uh, the public transport system in Pakistan is disgusting, to say the least. People share a really small confined space. Anyone who's had a seat in public transport or in a wagon, I've had my share in my day, and it's a disgusting place to be at. There's no personal space. People smoke inside. People cough in your face. I've shared seats with goats and chickens. So the public transportation system needs to be overhauled. It's in shabby conditions, and this virus should sensitize us about general and public hygiene. And I think that because if you have pockets in small areas, you can contain that. But the public transport system has the potential to spread it to places which are difficult to reach. So yes, I would focus on the public transport system in that regard.
Okay, sir. Sir, I think this is the last question for now. What are the unique problems that the Pakistani public health sector have had to face during this pandemic?
Uh, this is a broken system. We have had excellent infrastructure, but the system was already broken. It has a lot of loopholes. We don't have a lot of accountability. Corruption is one end of things, and then we lack a good training model. When we talked about the idea that we as doctors have an open playing field, this probably was a blessing in disguise in some cases, but on a larger scale of things, this is a bad idea, because without protocols, there is a lot of margin for error, and people make mistakes, and when there is lack of accountability, people tend to act more irresponsibly. So I guess more accountability, more responsibility, and a system that is based on scientific evidence and problem-based learning rather than anecdotal evidence. Yes.
Thank you, sir. I would now like to conclude the question answer session. Thank you so much for your time, sir. Thank you for all this information. We all really enjoyed it. I will head this over to Maham, Dr. Maham.
Good. Thank you for having me.
Thank you
Thank
so
you,
much,
sir.
Dr. It was a very insightful session. This concludes our session for tonight. I would like to thank all the professors for giving us their time and valuable information and for joining us from so far away to share their experiences. Thank you to the participants for joining us. We hope that you've gained as much as we have through this session. Please do not forget to fill the feedback forms as certificates will be distributed based on that. Thank you, Mavish, for being an amazing co-host and the rest of the team for helping us conduct this session. Our next session is going to be next weekend on the 15th and 16th of August, same time, same virtual space, and we will be discussing dentistry and surgery related COVID concerns. See you all then. Happy Independence Day in advance. Thank you everybody from my side. That's it. Over to you, Mavish.
Thank you so much, Dr. Maham. It was wonderful hosting with you as well. Thank you to our speakers for sharing such beneficial information and taking out such valuable time to increase everybody's knowledge. Thank you to all the participants for tuning in. A special appreciation for Professor Samia for all her efforts. She is our patron as well as our advisor for the academic team, and this series would not have been possible without her. Thank you, Dr. Sabah Akhtar, co-founder of VFP and also the advisor for academic team. She has been the backbone of our team. Thank you, Mr. Iftikhar Izdani, CEO of Rahe Kamar and a partner of VFP. His company provides voluntary IT services for this noble cause. Thank you, Dr. Rabil Tariq, co-founder of VFP, Mr. Sohaib, Mr. Zed, and many others for supporting us throughout the session. During this pandemic, while we practice social distancing, these series are an attempt by us to stay connected and share knowledge. So do make sure that you tune in next time and you are online, social online, as we face this and address the pandemic together. Thank you so much on behalf of Team VFP, Team Yardim, and RMU. Happy Independence. Hafiz.